دي، والتوك على الام ار اي اوف سيريبرال فيزل وول ايميجينج. فيزل وول ايميجينج ام ار اي الحقيقه توك برضو جديد، وعايزين نسمع ونفهم تقصدي ايه.
حاضر.
لانه طبعا احنا في الام ار ايميجينج بيهمنا قوي اليومن وايه اللي حصل في اليومن، لكن الانترست ما كانش على الفيزل وول. فقولي لي هتصوري الفيزل وول ازاي، وهتعملي كومنت على الفيزل وول ازاي، والباثولوجي ديفرنت باثولوجيز على الام ار اي فيزل وول في السي ان اس. اتفضلي.
First I'd like to thank the organization committee. طبعا Professor Dr. أحمد فريد and أستاذنا الفاضل أستاذ دكتور إبراهيم لبدة، أستاذ دكتور هاني رجب هاني، أستاذ دكتور محمود داوود، وطبعا أستاذ الدكتور هشام الشيخ على الدعوة الجميلة دي. أنا فعلا متشرفة بوجودي معاكم، وهبدأ على طول عشان الوقت شوية. أنا برضو في الأول حابة أشكر بروفيسور دكتور محمود موسى باشا. هي كان موضوع الانتراكرينيال فيسل وول ام ار اي ده كان رسالة الدكتوراه بتاعتي، وأنا عملته في جامعة واشنطن في أمريكا، ويعني هو لي الفضل بعد ربنا إن أنا اتعلمت التكنيك ده وإن أنا شفت الحالات دي. First, well, as Professor Dr. Ahmed Farid said, you know, when we talk about the vessel, intracranial vessels, all we have is like the luminal imaging, and actually that's not totally accurate, because funny how the pathology is in the vessel wall itself. Luminal imaging, distal subtraction angiography, and other tests can't usually allow us to see what happens in the wall itself. But thanks to this new emerging technique, we can see what the pathology of these different diseases. As I said before, the caster angiography, lumbar puncture, and brain biopsy are all invasive techniques that's used for diagnosis, and actually they lack the sensitivity and specificity because they don't know where to take the biopsy from. And I'll start shortly with describing the anatomy of the circle of Willis. Well, we have the axial and coronal MRA, as you can see here on the contours now. As you can see here, the basilar artery, and where it comes from, two vertebral arteries into the posterior circulation, and then we have the two internal carotid arteries with laterally two middle cerebral arteries, anterior cerebral and the ACOM. So I'm going to talk about the technique and the protocol of imaging. Actually, we did this test on 3 Tesla MRI because we wanted to increase the signal-to-noise ratio, and we used the head coil, of course. So the actual protocol that we used was the usual MRA, the vessel wall of the vessel lumen, and then we did the protocol of the vessel wall imaging, which is a 3D T2, T1 pre and post contrast, with the blood suppression technique. That's the parameters for the vessel wall imaging. So the main issue here, or the main concern, is to suppress all the signal from the blood and from the CSF, so that we can have a good contrast between the vessel wall and between the lumen itself. And we can also compare the lumen with the surrounding texture, or surrounding parenchyma. So we have something called Dante pulse, or pre-pulse. It's a short of it's an abbreviation of a long delay alternating with nutation for tolerated excitation. What it actually do, without entering في physics كتير يعني، إن هي just suppress the CSF and suppress the blood signal without doing any noise or any artifact on the tissue itself. So it was really perfect. And I'm doing a 3D VRFA vessel wall imaging technique. So why I'm not doing a 2D, I'm using a 3D technique here because I'll be doing a perpendicular axis on the vessel itself. And as you know, the circle of Willis, it just has small vessels and the lumen is oblique. So I need to be more perpendicular in every vessel so that to delete or to cancel any volume averaging artifact and to have an estimate accurate estimation of the vessel wall thickness. So I'd like to show you something about that's the first slides of the vessel wall imaging. First, to know, before we talk about the pathology, you need to know the normal appearance of the vessel wall. These slides have pathology, but as you can see here, that's the normal appearance of the vessel wall. It has a smooth smooth wall with minimal or no contrast enhancement, and there is I can appreciate the lumen very well without any narrowing. So I'm going to talk about the main pathology of intracranial vessel wall, which is atherosclerosis, myomyosis syndrome, vasculitis, and reversible cerebral vasoconstriction. As for atherosclerosis, I'm going to talk short about the pathogenesis of the disease. Well, it starts usually with an entemal thickening, and then smooth muscles and lipid put comes to this thickening, and then afterwards there is fibers. We have these fibrous caps that separate the plaque of the atherosclerotic plaque from the lumen itself. So the process of atherosclerosis is usually an active process, which means that there is an inflammation, there's new vessel formation, and these new vessels that's done is usually immature, and that's prone to rupture and causing intraplaque hemorrhage. And that's the first most important thing that we look at the plaque, the hemorrhage itself. And there are other things to look at the atherosclerotic plaque, which is the luminal morphology and ulcers. Usually the surface of the plaque is smooth, but it can be irregular, or worse than that, it can have an ulcer. An ulcer is defined as 1 millimeter defect in the in the fibrous cap. So what happens actually when the fibrous cap is very thin or ulcerated, there is as you can see, the platelets come, and there is a thrombus formation because it exposed the lumen to the lipid-rich necrotic core. So as I said before, that there is a lipid-rich necrotic core comes, and the size of this lipid-rich necrotic core differs outward. I mean, it's very important actually in the plaque composition, because it makes the plaque more vulnerable and more prone to rupture. So the things that I talked about, or the most important 3 things about the plaque, is the fibrous cap, the thickness of the fibrous cap, and the plaque hemorrhage, and the lipid core itself in the plaque. There is something that's characterizing the atherosclerotic plaque. It's something called positive remodeling, which it's only related to this disease, not found in other disease. Well, about the vessel remodeling, it's kind of tricky, because what happens here is the vessel wall gets dilated, and when it gets dilated, on the MRI, the normal actual luminal MRI, I can't see the vessel, I can see the stenosis. I'll find it a normal caliber, or there will be a minimal stenosis at the vessel. Whereas the opposite of that, as you can see downwards, the negative remodeling, which is the normal that we see, is the stenosis that happens in the vessel wall. So we talked much about atherosclerosis. When I see the images, how can I interpret it, what's important to see? Well, actually, what's characterized the atherosclerotic plaque is that it's eccentric. So it means that it takes focal segment of the vessel wall itself. It's not symmetrical. And actually, I would like to check on T2 weighted image, because the T2 will show me the different composition of the plaque. The plaque contains calcium hemorrhage, contains the lipid-rich core, and the fibrous cap. So that's the first image here that we're having, and as you can see, the first one, or A image, it was an 58 years old patient with has and have multiple risk factors for atherosclerosis. There is the time of flight MRI. You can see there is stenosis of the left middle cerebral artery, and as we do, the first one, the number B, is the protein density, and vessel MRI, and C is the post-contrast T1 axial images. You can appreciate the eccentric affection of the vessel wall from the atherosclerotic plaque, which takes an homogeneous avid enhancement in the post-contrast image, which means that it's active and it's inflamed. Well, that's actually what we see here about the composition of the plaque itself. The red arrows, the very dark signal is the calcification in the plaque, and the yellow arrow is the lipid-rich necrotic core. It usually shows iso-intense signal on T1, and it's low signal intensity on T2, and it doesn't enhance. And well, we have these small arrowheads. The yellow ones are the thin fibrous cap, and the green arrow is the enhancement in the plaque. That's another also one of the axial and coronal images. I'm sorry, that's the coronal images of the vessel wall imaging. And as you can see, there is enhancement of the plaque and eccentric involvement. Oh, here's this plaque has, the first one is the pre-contrast T1. As you can see, there is a high intense signal inside the plaque, which means there is hemorrhage inside this plaque. And on the second one, B, you can see there is a luminal irregularity and there is interrupted fibrous caps. That means that it has an ulcer. And it's also noted in the slide C, which is the MRA, and the histology. It shows as well the ulcer. So moyamoya zeta moyamoya syndrome. Okay, we all know about the moyamoya. It's the stenosis or occlusion of the terminal internal carotid artery and the middle cerebral artery, and actually we have to differentiate between moyamoya disease and syndrome, because moyamoya disease is actually idiopathic. It doesn't have an etiology. So actually what we do is a bypass between the extracranial internal carotid and the MCA, while the other one, the syndrome, is actually has a reason like atherosclerosis or radiation, so it can be treatable. So what I'm going to see in the vessel wall imaging of moyamoya, of course, we can see at the distal subtraction image, the first one, you can see the stenosis or the occlusion of the distal internal carotid arteries, the terminus part, with the thick arrow, and the small arrow shows the collateral circulation or the collateral vessels that come to compensate. At the T2 weighted vessel imaging of the MRI of the vessel wall imaging, you can notice that there is some kind of stenosis, and but there is stenosis only in the vessel wall, and the post-contrast axial and sagittal images shows no or minimal enhancement. Where about the vasculites, it's like an infection or inflammation of the vessel walls of the brain. And what I see in the vasculites and the vessel wall imaging is simply here. Well, you can see that there is symmetrical. It usually involves the whole vessel. So it's circumferential, smooth, and symmetrical, and usually enhanced avidly because it's an inflammation process. So you can see here, B and C is the pre and post contrast images. You can see here, you can appreciate the avid enhancement and the circumferential involvement of the vessel at slide C. Reversible, what I need to say about the vasculitis cases, that the most important thing is that after the patient gets treatment, the inflammation or the enhancement subsides, but stenosis will be present, and that's very important to differentiate it from the reversible cerebral vasoconstriction syndrome. The patient here comes, usually a female, comes with a central clap headache, and the problem is that she has a problem with defecation or urination or cough. She's actually doing her usual activities, and she got this headache and stroke. But then, the etiology is not usually known, but they said it's like an infection, inflammation, or excessive sympathetic activity. So what we can see here in the reversible cerebral vasoconstriction syndrome is that you'll find there is a smooth and concentric narrowing of the vessel, and usually it says no or minimal enhancement. And that's the C is the MRA image. You can see is still the narrowing on the vessel, but number D is the follow-up after 3 months. It returns to normal totally, and that's the difference between this and the vasculitis case. So, in summary, to sum up the case, we have a vessel wall affection. How to interpret it? Well, we see at the affection of the vessel wall, either it's circumferential or eccentric. If it's eccentric, it's going to be atherosclerosis. And if it's circumferential, it's going to be either vasculitis, reversible cerebral vasoconstriction, or moyamoya disease. So if I diagnose it as atherosclerosis of the eccentric enhancement, I'm gonna say I'll look at T1 and T2 weighted image and the pre and post contrast, of course. I can see the calcification, it gives me a dark signal intensity, a hemorrhage, it will be bright signal at T1, and lipid is gonna be ISO intense signal on T1, and T2 will give me low signal and the lipid core won't enhance. So if I find it as circumferential wall involvement, the next thing is that I have to differentiate. So moya, I'm telling you, we only depend on also the pattern of the puff of smoke and stenosis. And the reversible cerebral vasoconstrictor syndrome, it returns to normal after the follow-up after 3 months. And the vasculitis it's smooth circumferential enhancement that will subside after 3 months after the treatment, but stenosis will still be present. And it's the last slide here, it's the vulnerable plaque, the vulnerable atherosclerotic plaque, which is more important. دي أهم حاجة هنا عشان نقول للكلينيشن تتدخل وتلحق العيان قبل ما يحصل له ستروك ولا لا، برضه الستيبل ولا لا. أول حاجة الفايبرس كاب thickness هو thin ولا thick ولا fissured. الالسر بتاعت الفايبرس كاب اذا كان ulcered ولا لا. الليبيد ريتش نكروتيك كول لان السايز بتاعه كل ما بيكبر كل ما بيخلي البلاك برون اكتر انها ترابشر. المايكرو كالسيفيكيشن بتعمل شيرنج موفمنت بتخلي البلاك انها ترابشر برضو. واخر حاجه الانهانسمنت والبريزنس اوف هيموريدج. Thank you.